Hello, everyone. Our topic today is about rheumatology. These are our objectives of this presentation. Systemic rheumatic diseases spectrum and systemic rheumatic diseases therapies. The spectrum, number one, is arthropathies and arthritis. The difference between arthritis and arthropathies: arthropathy is a degenerative phenomenon, while arthritis is an inflammatory phenomenon. Connective tissue diseases, vasculitis, metabolic bone diseases, functional diseases such as fibromyalgia, overlap syndromes. Therapies starts from paracetamol, NSAIDs, steroids, colchicine, biologic DMARDs, and non-biologic DMARDs. Basic but important concepts in rheumatology. First, systemic rheumatic diseases is about pattern recognition. Systemic rheumatic diseases are probably chronic, systemic, autoimmune, connective tissue disorders with possible family history and HLA association, characterized by articular and extra-articular involvement. Clinically, systemic rheumatic diseases are usually presenting as general symptoms such as fever, fatigue, weight loss, malaise, and others as well. Articular manifestations and extra-articular manifestations. Labs include CBC, CRP, SID rate, inflammatory markers, serological markers, and synovial examination. Imaging includes articular such as X-ray, ultrasound, MRI, and extra-articular. Sometimes biopsy is needed. Treatment of rheumatic diseases include rest, physiotherapy, splinting, NSAIDs, steroids, DMARDs, and pain interventions. Of course, each disease has its specific pattern. Okay, that's why we're always talking about pattern recognition. Okay, but I'm just giving you like a quick review to most of the rheumatic disease. Arthritis can be classified to osteoarthritis, inflammatory arthritis, and septic arthritis. Osteoarthritis is the commonest form of rheumatic diseases. Etiology is usually primary, but it could be secondary as well. Females are more than males, 2 to 1, and usually in elderly patients. It affects knees, feet, spine, hands, and wrists, associated with Heberden's nodes. Can affect TMJ joints. Primary, related to aging, mechanical stress, hereditary. Secondary, related to obesity and trauma. Killian-Lawrence grading scale for knee osteoarthritis. It goes from grade 1 to grade 4. I would like to explain that, osteoarthritis is partly degenerative and partly inflammatory. The degenerative part is the predominant component, and this is basically the nociceptive pain, okay? And partly inflammatory, and it happens when the synovium kind of get inflamed and cause synovitis. And I'm sure that all of you guys are, familiar with elderly folks talking about their knees started to swell and is getting a little bit warm and, looks a little bit reddish. This is usually synovitis. Anyway, the Skelligren-Lawrence grading scale helps us, planning the therapy here. For grade 4, which is bone and bone, usually we proceed with, the usual medications, plus we do radiofrequency. Grade 2 and 3 is where you can do some steroids. You can do also plasma, platelet-rich plasma, and also hyaluronic acid injections. Weight reduction plays an important role in pain relief for patients with knee osteoarthritis. Rheumatoid arthritis is an autoimmune chronic systemic disease characterized by arthritis bilaterally, deformities such as the boutonniere deformity of the thumb, ulnar deviation at the MP joints, swan neck deformities in the feet, hammer toes, and hallux valgus, rheumatoid nodules, this is an X-ray for rheumatoid arthritis patient. Look at the ulnar deviation. The American College of Rheumatology, the ACR, and the European League Against Rheumatism have criteria for the diagnosis of rheumatoid arthritis. First is the joint involvement. Second is the serology. Third is the acute phase reactants. Fourth is the duration of symptoms. A total score of more than 6 indicates a diagnosis of rheumatoid arthritis. I want to mention here in the serology, the RF factor is screening because it's sensitive. And the anti-CCP is confirming because it is specific. So we use RF to screen rheumatoid arthritis, but we use anti-CCP to confirm the presence of rheumatoid arthritis. This is a comparison between osteoarthritis and rheumatoid arthritis. Osteoarthritis is not an autoimmune disease. It's a degenerative disease related to age, obesity, related to traumas. This is it could be hereditary. This is about osteoarthritis. Patients with osteoarthritis have morning stiffness less than 30 minutes. They have Heberden's nodes, and the distribution is asymmetrical. It affects the spine, the knees, and the hands. It's characterized by cartilage loss. Rheumatoid arthritis, on the other hand, is an autoimmune disease. It's characterized by inflamed synovium, morning stiffness lasting more than 30 minutes, extra-articular manifestations, and it is symmetrical in distribution. Juvenile arthritis is basically a subtype of arthritis that occurs in adolescents, children and adolescents. And it's a big term, like an umbrella, to 7 types of arthritis: oligoarthritis, polyarthritis rheumatoid factor negative, polyarthritis rheumatoid factor positive, enthesitis related arthritis, psoriatic arthritis, systemic onset juvenile idiopathic arthritis, and undifferentiated arthritis. We'll jump into another topic here, Sjogren disease. This was named after the Swedish eye specialist, Dr. Henrik Sjogren. Sjogren syndrome is basically dry nose, dry eyes, dry throat, dry skin. It's affecting also the joints. It can cause liver abnormalities, muscle pain, and neurological problems. These are the criteria for Sjogren syndrome. Ocular symptoms: dry eyes for more than 3 months with foreign body sensation. Use of tear substitutes more than 3 times a day. Oral symptoms: feeling of dry mouth, recurrently swollen salivary glands, frequent use of liquids to aid swallowing. Ocular signs: Schirmer test performed without anesthesia, less than 5 millimeter in 5 minutes. Positive vital dye staining results. Oral signs: abnormal salivary, lacrimatory, and parotid findings. Unstimulated salivary flow, less than 1.5 ml in 15 minutes. 5 is positive minor salivary gland biopsy findings. 6 is positive for SSA or SSB autoantibodies result. So these are the 6 criteria for Sjogren syndrome. There is a primary form and there is a secondary form. Filthy syndrome. This is a syndrome that occurs in adolescence. Basically, it's a rheumatoid arthritis associated with splenomegaly, anemia, neutropenia, and thrombocytopenia. Systemic lupus erythematosus. It's an autoimmune disease in which the body immune cells attacks healthy tissues in many parts of the body. Systemic lupus erythematosus are characterized by, first, it affects ladies, usually, age between 20 to 40. More common in Afro-Caribbeans. CNS manifestations happen in 50% of the time, characterized by headaches, polyneuropathy, stroke, psychosis, depression, epilepsy, skin manifestations, photosensitivity, malar rash, non-specific erythema, lungs. The malar rash is basically one of the pathognomonic features of systemic lupus. Lungs, affected in 50% of the time. Lupus pneumonitis, pulmonary fibrosis, honeycomb lung, pleurisy, patchy consolidations, areas of collapse, shrinking lungs, uncommon but characteristic. Cardiovascular, affecting 40% of the patients. Pericarditis, splenomegaly. Renal, affected in 100% of the patients. Almost any manifestation of renal disease, including hypertension and nephrotic syndrome. Joints are affected in 90% of the cases. They're basically migratory and asymmetrical polyarthropathy, affecting the fingers, wrists, elbows, shoulders, knees, and ankles. Also, there are manifestations of anemia of chronic disease and hemolytic anemia in 10% of the cases. This is basically the ACR EULAR 2019 criteria for diagnosis of systemic lupus. Constitutional, fever, cutaneous, alopecia, oral ulcers, subacute cutaneous or discoid, acute cutaneous lupus, arthritis, synovitis in 2 or plus joints, more than 30 minutes of morning stiffness, neurologic, delirium, psychosis, seizures, sinusitis, pleural or pericardial effusion, active pericarditis, hematologic, leukopenia, thrombocytopenia, autoimmune hemolysis, renal, proteinuria, class 2 or 5 lupus nephritis, class 3 or 4 lupus nephritis, antiphospholipid antibody, such as anticardiolipin IgG more than 40, lupus anticoagulant, complement, low C3 or C4, highly specific antibodies. This is important. Anti-dsDNA and anti-Smith. So compared to rheumatoid arthritis, the screening test is ANA. Okay? The confirming test is the anti-dsDNA and the anti-Smith. So the screening test is the sensitive test, and the confirming test is the specific test. So again, screening for lupus is ANA. Confirming is anti-dsDNA and anti-Smith. Antiphospholipid syndrome is one of these syndromes that we see sometimes in our pain clinic. This is characterized by migraine, stroke, transient ischemic attacks, pulmonary embolism, renal vein thrombosis, thrombotic microangiopathy, recurrent early miscarriages, intrauterine fetal death, deep vein thrombosis, Raynaud phenomena, and lividio reticularis. So many times they send these patients to our pain clinic for pain control. Seronegative spondyloarthropathies, ankylosing spondylitis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease, arthritis, ankylosing spondylitis, usually in males, characterized by stiffness in the lumbar and the rest of the spine, also sacroiliac involvement. Patients have limited range of motion as the disease progresses. It affects also breathing. Famous test is modified Schubert test, which basically depicts limitation in flexion of the lumbar spine. X-ray will show bamboo spine, which is basically calcification of all the ligaments, connecting the spine together. Psoriatic arthritis, characterized by the characteristic psoriasis rash, dactylitis, sausage-like fingers and toes, arthritis mutilans, also enthesitis to the Achilles tendon, reactive arthritis, also known as rheumatoid arthritis, symptoms of enteric or genitourinary infection, musculoskeletal problems such as arthritis, enthesitis, dactylitis, back pain, extra-articular such as conjunctivitis, urethritis, oral lesions, skin changes. They have this nice mnemonic: cannot pee, cannot climb a tree, cannot see. And it's positive for the HLA-B27. Same thing, same token with ankylosing and other negative spondyloarthropathy, the negative HLA-B27. Hans Ritter, the discoverer of reactive arthritis. Enteropathic arthritis. This is a kind of negative spondyloarthropathy that occurs with inflammatory bowel disease such as ulcerative colitis and Crohn's disease. Characterized by uveitis, pyoderma gangrenosum. This is pathognomonic, guys. Erythema nodosum, also pathognomonic, and oral ulcers. Besides the usual articular and extra-articular symptoms and signs that occurs with negative spondyloarthropathy. Negative spondyloarthropathy means the rheumatoid factor negative, okay? Just to, make a distinction from rheumatoid arthritis. Other rheumatic diseases, polymyositis or dermatomyositis. And they have an old criteria by Bohan and Peter. A lot of people still use it, but there are newer, classifications and criteria nowadays. Symmetrical proximal muscle weakness, elevation of the skeletal muscle enzymes such as the CK, LDH, AST, ALT, and aldolase, muscle biopsy with evidence of myositis, EMG pattern of myopathy, typical rash of dermatomyositis, photosensitive rash, heliotrope rash, and Gottrin papules. Look at the Gottrin papules in the hand here and the heliotrope rash underneath the eye. There are related syndromes. They're actually, they're all under the same umbrella. First of them is the polymyositis, dermatomyositis that we just talked about. And this is characterized by the heliotrope rash, also the Gottrin's papules, characterized by positive, also proximal myositis. Also, lab-wise, positive ANA and positive to CK and other muscle enzymes. There's a related syndrome called anti-synthetase syndrome, characterized by fever, positive for JO1 antibody, characterized also by interstitial lung disease, arthritis, Raynaud phenomenon, mechanic hands, and another disease called the inclusion body myositis. Okay, it's characterized by distal myositis. I mean, as you see, the rheumatology is a pattern recognition. So how would I differentiate between inclusion body myositis and polymyositis? One of them is proximal, the other one is distal. Okay. The other point I want to take from here is we use sometimes biopsy to confirm our diagnosis. Not only imaging, not only labs, sometimes you need to do a biopsy. And we mentioned this in the first part of the lecture. Scleroderma. Scleroderma are two types, localized and systemic sclerosis. Localized, such as morphia and linear, and this is something that you don't have to worry about because this is more or less like a skin disease. Okay, dermatology will take care of these folks. And you have systemic sclerosis, which is basically limited or diffuse. Limited shows slow progression, little or no skin thickening, muscle tendon inflammation uncommon, kidney disease uncommon, positive anti-centromere antibody. Diffuse, more rapid onset and progression, rapid skin thickening, muscle and tendon inflammation common, internal organ involvement usually early, kidney disease common, positive anti-SCL70 antibody. Okay, and then we have shared symptoms and findings. Esophageal dysmotility, Raynaud's syndrome, telangiectasia, sclerodactyly calcinosis. And then you have increased chance of osteoporosis, increased chance of cancer, overlapping diseases, and increased chance of celiac sensitivity. The point is how to differentiate between limited and diffuse. One of them is positive to anti-centromere, and the other one is positive to anti-SCL70. And both of them are called systemic sclerosis, or all of these are under the umbrella of scleroderma. Okay, so scleroderma could be localized or systemic sclerosis. This is the big umbrella of all these diseases. Also, you will see in scleroderma striation of neck called the Barnett sign. You will see also the salt and pepper sign in the skin. Limited symptoms of scleroderma are referred as crest. C for calcinosis, basically calcium deposits under the skin. Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, which means thickening and tightening of the skin on the fingers and hands. Telangiectasia, dilatation of capillaries, causing red marks on the surface of the skin. Systemic sclerosis can affect internal organs. And you can see here from the picture affecting the heart and the lungs and the esophagus. We'll shift topics to vasculitis. And this is a big picture of vasculitis diseases. We have large vessel vasculitis, we have medium vessel vasculitis, and we have ANCA associated small vessel vasculitis, and we have immune complex small vessel vasculitis. Again, you have large and medium and small. The small are immune complex, small vasculitis, and ANCA associated small vessel vasculitis. Giant cell arthritis is a very important disease in rheumatology, and it could be a medical emergency characterized by inflammation in the vessels that's called the superficial temporal artery. Most commonly in females more than 55 years old, associated with a condition called polymyalgia rheumatica, and should be treated aggressively with steroids because it can cause blindness. And it could be also associated with aortic aneurysm and stroke. Takayasu arthritis, or pulseless disease, usually affects Asian women above 40. Limb ischemia, progressive claudication, organ ischemia, systolic blood pressure discrepancies between the limbs. SED rate may be elevated, and the diagnosis is angiography, showing the stenosis and aneurysm. Takayasu arthritis affects the aorta, while giant cell arthritis affects the carotids. Be careful about this part here. Biopsy usually not needed in Takayasu. Angiography is diagnostic. But in GCA, biopsy is important. Okay? However, you should start the steroids anyway until you get the biopsy results. Okay? And this is basically Dr. Takayasu, the founder of Takayasu Arthritis. Polyarthritis nodosa, or necrotizing inflammation. It's a necrotizing inflammation affecting the median arteries, especially at branch points. Ischemia most often affects the nervous system. Mononeuritis multiplex, asymmetric polyneuropathy. It might affect median nerve, ulnar nerve, fibular nerves, sensory and motor deficits, renal, hypertension, oliguria, may lead to renal failure, GI, abdominal pain, malabsorption, aneurysm, possible fatal. Skin, lividio reticularis, ulcers, subcutaneous nodules, gangrene. Polyarthritis nodosa is systemic and cutaneous. Some secondary forms are related to hepatitis B or hepatitis C viruses. Most commonly affect men above 50 years old. Heart failure could be related to coronary artery obstruction. Kawasaki disease. Kawasaki disease is basically a mucocutaneous lymph node syndrome. It's a rare childhood disease that causes inflammation in the walls of small-sized and medium-sized arteries, most often in children under the age of 5 of Asian descent. It is somewhat more common in boys than girls, characterized by fever for more than 5 days. Eyes shows conjunctival redness, swollen lymph nodes, widespread rash, cardiac complications in 5 to 20%. And we have a mnemonic for it: cream, conjunctivitis, rash, edema in the hands and feet, adenopathy, and mucosal involvement, what we call strawberry tongue. Complications are coronary artery aneurysm, myocarditis, and usually treated with high-dose aspirin. So this is one of these situations where you give aspirin in patients less than 16 years old. Kawasaki disease, first described by Dr. Tomisaku Kawasaki from Japan. Kawasaki disease is rare, but it's a fatal disease. Okay, we have other diseases like Wegener, Sturge-Strauss, and MPA. Wegener is characterized by sinusitis, subglottic stenosis, pulmonary nodules, orbital pseudotumor. Sturge-Strauss by hypereosinophilia, asthma, pulmonary infiltrates, and myocarditis. Okay, MPA characterized by pulmonary capillaritis, glomerulonephritis, sensory neuropathy, and mononeuritis multiplex. So as you see, the three of these diseases, they overlap with each other. But, you know, if you look carefully, each of them has specific or special features. Like, for example, with Sturge-Strauss, you know, remember, hypereosinophilia and asthma. Okay? So this is something that, you know, you will see mainly in Sturge-Strauss. Wegener's, you see more of a sinusitis. Okay? The MPA, you will see the mononeuritis multiplex. Wegener's, nose stuffiness, nose bleeds, sudden nose. I've seen, you know, a couple of these patients in my career. They were sent to me for pain control. I'll be honest with you, there was nothing I can offer except, you know, regular, you know, analgesics, sometimes, you know, opioids, but in, you know, very small doses. These guys are characterized by pericarditis, nodules in the elbow, glomerulonephritis, lung infiltrates, and pseudotumors in the eye. So remember, Wegener affects mainly the nose and the sinuses. Sturge-Strauss, again, this one affects medium and small vessels, mainly the lungs, gastrointestinal system, and peripheral nerves. Patients complain of asthma, allergic reactions. All right. When you do a CBC, you will find increased eosinophils. And also you'll find increase in P-ANCA, which is basically the nuclear pattern of anti-neutrophil cytoplasmic antibodies. You don't have to remember all this name. P-ANCA for Sturge-Strauss. Okay, and I put here down on the right side the criteria for Sturge-Strauss: asthma, eosinophilia, neuropathy, pulmonary infiltrate, paranasal sinus abnormalities, and extravascular eosinophils. Okay, differential diagnosis is polyarthritis nodosa and Wegener's. Wegener's C. ANCA. Okay, so with Wegener, it's positive for C. ANCA, while Sturge-Strauss is P. ANCA. Okay, this is basically Wegener. C. ANCA, positive C. ANCA. Sturge-Strauss, positive P. ANCA. Discovered by Dr. Shirk and Dr. Strauss. Henoch-Schwann-Purpur, or HSP. It's a systemic vasculitis, inflammation of blood vessels, characterized by deposition of immune complexes containing the antibody IgA, characterized by rash, arthritis, abdominal pain, and hematuria. And usually it happens in the adolescence. Discovered by Dr. Edward Heinrich Henoch. Cryoglobulinemia, a similar syndrome characterized by fever, general symptoms, athenia, arthralgias, myalgias, organ-specific symptoms such as purpur, glomerulonephritis, peripheral neuropathy, interstitial lung disease, and digestive involvement. Urticarial vasculitis, rare, inflammatory injury of the capillaries. Usually, it's a manifestation of systemic disease. It's characterized by hives persisting for more than 24 hours. That is basically periuretic. Painful, stinging, burning sensation. Leaves a trace. Faint residual hyperpigmentation, indicating red cell extravasation. Behçet syndrome. It's a multi-system inflammatory disorder characterized by oral and genital ulcers, described by the Turkish dermatologist Hulusi Behçet in 1937, prevalent in the Middle East and Asian countries. Slightly more common in women, age of onset usually 30 and 40 years. Involvement of the nervous system is reported in 20%. Symptoms include oral, genital sores, inflammation of the eyes, joints, and gut. Diagnosis is usually clinical, treated with anti-inflammatory drugs and immune suppressive drugs. I've seen only one case of Behçet syndrome, and patient was really miserable. He was a young guy and was also a drug seeker, unfortunately. Gout. This is a disease that affects the joints, starts usually in the foot, what we call a podagra, by deposition of crystals in the big toe here, and also it can deposit in the subcutaneous area, in the ears and other areas. The differential diagnosis of gout is pseudogout, which is characterized by deposition of calcium pyrophosphate dihydrate, while gout is deposition of monosodium urate. This one, the gout is strongly negative birefringent needle-shaped crystals, while the CPP is weakly positive birefringent rhomboid-shaped crystals, blue when parallel to the polarizer. With gout, it's yellow when parallel to the polarizer. So basically, to differentiate between gout and pseudo-gout, you have to take a specimen, synovial specimen, send it to the lab, and you should be able to differentiate between both diseases. But usually CPP affects more of the knees. You know, this one, usually the gout starts with the big toe. I want to give you a quick idea about, you know, medications that we use for systemic rheumatic disease. First, we'll start with the non-steroidal anti-inflammatory drugs. Okay, paracetamol, by the way, is considered an NSAID, but usually we keep it as a separate entity because it works a little bit different than the rest of the NSAIDs. Works centrally, usually, and doesn't have an anti-inflammatory properties that like the rest of the NSAIDs. That's why we always say paracetamol and NSAIDs. But in fact, you know, it's an NSAID. I hope this didn't confuse you, but I just wanted to make it clear. So, for example, if you have an osteoarthropathy, the American College of Rheumatology, their first choice is paracetamol because it's a degenerative disease usually, okay? And if this doesn't work, then we go to NSAIDs, especially if there's an inflammatory component to the osteoarthritis, okay? We're not going to talk about different types of NSAIDs, but we just, you know, we know that we have COX-1 and COX-2 inhibitors. And this is enough for this presentation. We have a full presentation about anti-inflammatory drugs. Please look it up. Also, corticosteroids play a major role in rheumatic diseases. Again, please look up the anti-inflammatory presentation. Okay, we're going to add other drugs called the DMARDs, disease-modifying anti-rheumatic drugs. And these are two types, non-biological and biological. Of course, the non-biological are the old ones, okay, and the biological of the recent drugs. And I just putting here a list of the drugs, the biological here. Like, for example, adalimumab, it's a tumor necrosis factor inhibitor. Golimumab, tumor necrosis factor inhibitor. Etanercept, it's a decoys tumor necrosis factor receptor. Infliximab, tumor necrosis factor inhibitor. Anakinra, interleukin-1 receptor antagonist. And we can keep going on and on. Tocilizumab, interleukin-6 receptor antagonist. Okay, so for rheumatology fellows, this really matters. Okay, these mechanisms of action. And because if you understand the basic pathophysiology of the disease and which mediator is involved, you'll be able to prescribe the right biological DMARD. I hope this is very clear. So I put the mechanisms here. I don't want you to memorize it or anything, but I want you to understand that this has a clinical implication for rheumatologists. Okay. Then you have the non-biological here, such as chloroquine, azathioprine, leflunomide, methotrexate, sulfasalazine, hydroxychloroquine. The most important one that you need to know about is methotrexate. And next is sulfasalazine and hydroxychloroquine. Usually we start with the non-biological, and if the non-biological does not work, we substitute with biological or add a biological. You can add a non-biological to biological DMARD, but you cannot add a biological to biological. Because you're gonna be suppressing the immune system big time. Colchicine, this drug is used for prevention and treatment of gout. Okay. Nowadays, they found it has a use in as a secondary cardiovascular disease prevention because it's an anti-inflammatory on the coronaries as well. It's also been used in familiar Mediterranean fever and pericarditis. It's harsh on the GI, causing abdominal cramps and diarrhea. Not a lot of people tolerate it. And it has a drug interaction with statins. Be careful with that. It can cause myopathy, all right, if you add it to statin. So this is a problem in my mind. Like most of these chronic artery disease patients are taking statins. And if you add colchicine to it, it's not a good idea. So then you have to stop the statin and use something else. Okay. Septic arthritis. It's a medical emergency. All right. I've seen it only once. This is something that you have to admit the patient and get a full lab work and aspirate the joint and start IV antibiotics. Okay. And also blood cultures to start the antibiotics. Some of the regimens here, is like fluoxacillin, Cipro. Usually the length of treatment is 4 to 6 weeks, but I'm sure there are other regimens for, septic arthritis. Staph aureus is the most common causative organism. Gonococcus in young sexually active patients. E. coli in elderly and IV drug users. Okay, these are the labs for serologic markers for, rheumatic diseases. I want to make sure that you understand it. There are screening tests and there are confirming tests. Okay, screening tests are usually tests with high sensitivity. Confirming tests are usually highly specific tests. For example, rheumatoid arthritis. The screening test is rheumatoid factor, and confirming is the anti-CCP. Systemic lupus. Screening is ANA. Confirming is anti-Smith and dsDNA. Okay. Drug-induced systemic lupus is the antihistone. Dermatomyositis, anti-Jo1. Limited scleroderma, anti-centromere. Diffuse scleroderma, anti-SCL70. Scleroderma renal crisis, anti-RNA polymerase 3, Sjögren, anti-SSA, otherwise called Rho, and anti-SSB, or sometimes called LA. Congenital heart block associated with anti-SSA, Rho. Mixed connective tissue disease, anti-U1-RMP. Microscopic polyangiitis. Remember, we talked about it with Wegener and all that. It's positive to ANCA, to P-ANCA. Sjögren-Strauss, positive to P-ANCA. Granulomatous polyangiitis, also known as Wegener, C-ANCA positive. Now, as far as inflammatory markers, most of them are, you know, a positive to ESR and CRP. Maybe not with systemic lupus. With systemic lupus, you'll see a low C4 and C3. Okay? Systemic lupus is associated with antiphospholipid syndrome. What else I want to say here? I think we got it. Or dermatomyositis and polymyositis affect the muscle enzymes because it's a myositis. Okay, proximal myositis, and sometimes distal, like the inclusion myositis disease. This is a very nice table. I mean, it got it all, to be honest with you. Sjögren, anti-SSA, anti-SSB, positive SRDs CRP, causes Zika symptoms, and there's a risk of lymphoma. Okay, and so forth. I mean, it's a pattern recognition. Synovial fluids in normal patients, non-inflammatory, okay, like, for example, arthropathies, inflammatory and septic, and hemarthrosis. As you see here, with septic, you have neutrophils count more than 75%. And Gram stain is positive. Okay? Inflammatory, you can actually, like gout, for example. You can have a high neutrophilic count, but it doesn't exceed 75, usually above 50, and positive for crystals. Metabolic bone diseases, mineralization diseases, basically osteomalacia and rickets. Rickets is the childhood form of osteomalacia. Another metabolic bone disease is low bone mineral content, or osteoporosis. Osteogenesis imperfecta. These are low bone mineral content. High bone mineral content, such as osteopetrosis, bisphosphonates, and benign high bone mass. High bone turnover, like Paget's or hyperparathyroidism. Low bone turnover, such as adenemic disease. So I like this classification, guys, because I always get mixed in these metabolic bone disease. So if it's a problem with mineralization, it's probably osteomalacia / rickets. If it's a low bone mineral content, you know, or it will be osteoporosis or osteogenesis imperfecta. High bone mineral content, such as osteopetrosis. High bone turnover, such as Paget, and hyperparathyroidism. Low bone turnover, adenemic disease. Osteomalacia, This could be related to vitamin D deficiency, characterized by muscle pain and weakness, difficulty walking, painful bones and joints, and muscle cramps. Most common signs of osteoporosis: disease, decrease in the height over time, hunched or stooped posture, back pain, easier than usual bone fracturing. Differential features of osteoporosis and osteomalacia. Okay, one of them is osteomalacia is demineralized bone. Osteoporosis is decreased bone mass. This one is lack of calcium, lack of vitamin D in osteomalacia. You can have osteopenia fractures. Here you can have pseudofractures, looser zones and fractures. Calcium level normal. Here, because it's a vitamin D deficiency, it will be low. And so forth. Usually parathyroid hormone goes up with osteomalacia. Alkaline phosphatase is usually high in osteomalacia. Osteogenesis imperfecta. It's a rare disease, and there are different types. Type 1 is characterized by blue sclera and bone fragility, and usually the patient is usually stature is normal or mildly affected. Also, patients might have deafness in adult life. Blue sclera, deformed teeth, brittle bones. Osteogenesis imperfecta. It's divided into 1, 2, and 3, and 4. 1 is the commonest type that we just talked about. 2 is lethal. And then you have 3 and 4. 4 is not as severe as 3. But 3 is the most severe form that's compatible with life. We'll jump into an important topic called joint hypermobility. We have a score called the Beaton score. Okay, and this is from 1 to 9. And with Beaton score, you can detect hypermobility in the joints. And this could mean many things. Okay? And if you're above 5 out of 9, you're definitely hypermobile. One of the problems that you see is benign joint hypermobility syndrome. This is a very common problem, affecting almost 10% of adolescents. But it's not a severe problem. But these patients will have very flexible joints, and unfortunately, they might get injured because of that. They need education. And these are some of the connective tissue disorders affecting the joints, such as EDS, which is basically the most famous of them. It's affecting collagen. Marfan syndrome, affecting fibrillin. And pseudoxanthoma elasticum, which affects the elastin. Osteogenesis imperfecta also affects the collagen. Stickler syndrome. Ehlers-Danlos syndrome, at least 13 types. The most famous ones are the classical, and the vascular and the hypermobile. Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is a very important syndrome for pain physicians because usually these patients complain of bone and joint pain. Also, these guys are manifested with other phenomena that can cause, other types of pain besides the joint pain. One of them is Arnold-Chiari malformation, which basically means the downward displacement of the cerebellum. Okay, and Arnold-Chiari are basically 4 types, from 1 to 4. All right. Idiopathic intracranial hypertension, described with the Dandi's criteria. I just had a patient with idiopathic intracranial hypertension. It was a girl, 12 years old, severe headaches. I talked more about this in the headache presentation. Please look it up. But all of these are associations with EDS. This is the reason I brought it here to your attention here. So remember Arnold, and then idiopathic intracranial hypertension. Another association is spontaneous intracranial hypotension. And this one is similar to having a wet tap from an epidural needle, but without a wet tap, without a needle, okay? Also can happen with patients with EDS. Another problem is postural tachycardia syndrome, or POTS, all right? And these patients get tachycardic when they stand up because of autonomic dysfunction here. Another association with EDS. Also, mast cell activation syndrome, all right? Please remember these terminologies, okay? One of these days, you're going to meet an EDS patient that's having all these manifestations here. And this one is characterized by flushing of the face, neck, and chest because of the mast cell activation. Also, it can affect your cardiovascular system and GI, like diarrhea, nausea, vomiting, and so forth. So symptoms in mast cell activation syndrome can be sudden and unpredictable. Marfan syndrome affects the fibrillin. Remember, this patient discovered by Antoine Bernard Jean Marfan, a French pediatrician, characterized by ectopic lens, aortic dilatation or dissection, okay, mitral regurgitation, marfanoid habitus. It's usually related to chromosome number 15, affecting the fibrillin. Patients might have spontaneous pneumothorax and arachnodectomy. I remember a patient that came to me in the clinic. He was like 35 years old, and he had Marfan syndrome, and he was not actually diagnosed. And he was complaining of joint pain. That's all. So, of course, I sent him to a rheumatologist because I felt, this guy needs a full workup, on his body here. I don't know how he got missed all these years, but I just want to say sometimes you actually find these patients sent to you by a mistake. Marfan syndrome. wrist sign and thumb sign, very classic, okay, for Marfan, and arachnodactyly, scoliosis, lens dislocation, renal osteodystrophy. This is very important in palliative care in particular, okay, and in pain medicine, because these folks will come to you in the clinic, pain clinic, for bone pain. So renal osteodystrophy is basically a syndrome that starts with inability of the kidney to produce vitamin D25 hydroxide or activate the vitamin D in your body. And this starts a cascade of, metabolic complications here. All right. I'm not going to go in detail about these syndromes. You will find them in the palliative section here of my presentations for end-stage renal disease, if you need more details. But it can cause what we call osteitis fibrosa, osteomalacia, adynamic bone disease, and amyloid disease. Osteopetrosis or marble bone disease. It's an extremely rare genetic disorder of the bones, in which the bones get harder and denser. This condition, in turn, leads to bones getting dissolved and ultimately break. Osteopetrosis. Very pathognomonic, the X-ray. Key learning points. Again, systemic rheumatic diseases is about pattern recognition, guys. It's probably a chronic, probably systemic, probably autoimmune, probably connective tissue disorder, probably there's a family history. All of these features doesn't happen in the same disease. Some of them will have positive family history, some of them will not. Some of them will have HLA association, like HLA-B27, for example, in negative spondyloarthropathies, and some not. Some are characterized by articular and extra-articular involvement, and the extra-articular involvement is specific for each disease. With labs, you need to check inflammatory markers, serological markers. And we mentioned that there are screening tests and there are confirming tests. Imaging, articular, and then biopsy is important in some diseases, and we explain this part. Treatment of rheumatic diseases include NSAIDs, steroids, DMARDs, biological and non-biological, and pain interventions. Thank you.